Good afternoon. Thank you, Sakoma UK, for inviting me to give this brief talk. As you all know, sarcoma diagnosis can be quite problematic. If we look at this study that Cyril Fisher and others did at the Marsden a few years ago now, you can see that quite a significant number of cases that are reviewed at the specialist centers do pick up some discrepancies from the original diagnosis. And of the discrepancies that were picked up, about 16% showed major issues, and 11 or 12% showed minor discrepancies. And these factors are due to a number of factors. The number one factor is the fact that sarcoma is quite rare as compared to other tumors. So not many people, including histopathologists who have worked for years, would have seen many sarcomas, especially if they work in a general hospital. Maybe if you work in a general hospital, you only diagnose 1 or 2 sarcomas per year. So getting the necessary experience can be quite tricky in that scenario. And the other problem is the fact that the sarcomas themselves, they often show quite a diverse sort of histological appearance, including within a single entity. The appearances can be quite varied to such an extent that depending on where your biopsy is taken, the appearances may be quite difficult and quite different from the rest of the tumor, and that can lead to diagnostic problems. And also the fact that many entities are now there in the WHO book, and most of these entities often have overlapping features, and some are difficult to classify as either benign or malignant, and some can be even more difficult to separate from reactive conditions, especially on small biopsies. As you know, most of the diagnosis these days is made on small biopsies because that will inform the preoperative management of patients. So small biopsies can cause problems in diagnosis, but in experienced hands, the diagnosis can often be made safely. And also, due to the use of modern ancillary studies, immunohistochemistry, genomic studies, we are getting more and more new entities being described almost on a monthly basis now. Some of these new entities may have a bearing on the treatment, especially if they have got molecular targets that can be elucidated by doing molecular studies. Just to illustrate some of these diagnostic problems that we have, sometimes non-neoplastic lesions can mimic sarcomas. And if we don't get the necessary clinical information and we just get biopsies without adequate information, it can be quite tricky to make a diagnosis. Things like ischemic fasciitis, for instance, if you are not told that it's a lesion which is on a dependent part of the body and the patient is debilitated, morphologically it can look quite alarming and looks very much like a sarcoma. And if you get a small biopsy, it can be easy to make an erroneous diagnosis of sarcoma. And things like localized lymphoedema, they are simple diagnoses to make, but if you don't have the relevant clinical information, again, it can be tricky. This is just a case to illustrate some of the problems. This was a biopsy which was sent to a peripheral hospital as a lesion on the arm, and superficially it looked like a granuloma. So the initial diagnosis that was made was that of a granuloma. But then the lesion persisted and it was re-looked at, and then when you go to a higher power, it's quite easy to then appreciate that the cells that are, surrounding that area, central area, are actually atypical, and they may be, neoplastic, and this was then stained, and it was an epithelioid sarcoma. So this is an example of a sarcoma which can mimic a benign condition. And this is a granuloma annulare. So you can see on a low power, if one is not experienced enough and they just look at the biopsy on low power, they can make an erroneous diagnosis, and it might be months down the line when people actually realize that it's not just an inflammatory process. This is just to compare the two conditions. You can see that the epithelioid sarcoma looks quite similar, especially on low power, to granuloma annulare, which is a benign condition. And there are also some other benign lesions which mimic sarcoma. The example which is quoted most in the literature is fibromatosis and desmoid fibromatosis. Desmoid fibromatosis, in the right clinical context, with the right clinical information and a generous biopsy, the diagnosis is usually easy to make. But if you are not given the right clinical information, it can be tricky. You can see here it's a lesion which is quite infiltrative. It's separating some muscle of those pink blobs. Those are skeletal muscle fibers. And usually in histology, when we see a tumor which is quite infiltrative, it usually implies it's an aggressive tumor, and for inexperienced people, it can imply that it's a sarcoma. Particularly in the early phase of desmoid fibromatosis, it can be mitotically active as well. So it can be easy to make an erroneous diagnosis in such cases. And even with use of ancillary studies, it may not be helpful, because a lot of the immunostains that we do in desmoid fibromatosis also stain some of the tumors that mimic desmoid fibromatosis. For instance, this is smooth muscle actin, which will also stain leiomyosarcomas, leiomyomas, which are tumors of smooth muscle derivation. We can use what's called beta-catenin, which is like a surrogate marker of the underlying genetic abnormality that's found in desmoid fibromatosis. If it works, then the diagnosis is easy. In this case, you can see that there's good nuclear staining with beta-catenin, but unfortunately, it doesn't always work this well, which is why sometimes on small biopsies, desmoid fibromatosis can be quite difficult to diagnose. And in such scenarios, we actually have to do molecular studies to send off the material for mutation analysis to look for the underlying genetic abnormality that's found in these cases. And desmoid fibromatosis can also look very much like malignant tumors, especially low-grade fibromyxoid sarcoma. And this tumor shares morphological features with desmoid fibromatosis and can also be positive for SMA. And if you have beta-catenin immunostains, which an immunostain which doesn't really work well, it can be quite easy to confuse the two. Another example is of a benign lesion which mimic, or rather sarcoma which mimics a benign lesion, is so-called lipoma-like well-differentiated liposarcoma. This can be, again, a source of diagnostic difficulties, particularly if you don't have clinical information. If it's a superficially located lesion, which looks like this, it's easy to make a diagnosis of a lipoma, and the vast majority of those tumors will be lipomas. But this example I've put here is of a retroperitoneal tumor. If it's in the retroperitoneum, even if it looks like an ordinary lipoma, it's necessary to do ancillary studies to look for other things, particularly to exclude a well-differentiated liposarcoma, because those two tumors can look very much alike. In majority of cases, you can get a hint if you search for it, if it's a resection sample, where you look for atypical cells as illustrated on the right here. But again, as I said, these days we rely on small biopsies, and quite often the small biopsy only shows that kind of tissue there. So it's necessary to then be able to, put the clinical information together with what you are seeing under the microscope and order ancillary studies. In this particular instance, if you do molecular studies to look for, or rather cytogenetic studies to look for MDM2 amplification, the diagnosis becomes quite easy to make. As I alluded to earlier on, some entities within the field of sarcoma can have quite variable morphological appearances. And again, dedifferentiated liposarcoma is a good example of that. All these tumors that you are seeing in the different panels here, they are all dedifferentiated liposarcomas. But if you were to get a biopsy, from one area of those of the tumor, looking like that, like the right panel there, it can be easy to make a diagnosis of myxofibrosarcoma because it looks exactly like a myxofibrosarcoma. The one at the bottom looks like a pleomorphic liposarcoma. So again, clinical context is important to avoid mistakes. If it's a deep-seated tumor or a retroperitoneal tumor, intra-abdominal pelvic tumor, and it's looking like any of these high-grade undifferentiated malignant tumor, one ought to think, could this be a dedifferentiated liposarcoma, and do the relevant studies. Heterologous differentiation is another source of problems in our practice. Sometimes you get a biopsy which looks like an osteosarcoma. Depending on the site where it was taken, one ought to think, could this be just a divergent differentiation in some other tumor and not a bona fide osteosarcoma or chondrosarcoma or rhabdomyosarcoma for that matter. So if one is not looking at these tumors on a regular basis, you can see why it can be easy to make a mistake, because if you get a biopsy looking like an osteosarcoma, histologically it looks like an osteosarcoma, and if it was a bone biopsy, that would be an osteosarcoma, and you would have no problem in diagnosing an osteosarcoma, of course, with the relevant correlation with imaging. But if you get the same tumor looking like an osteosarcoma and it's in soft tissues, one ought to think, could this be something else, before you resort to making a diagnosis of an osteosarcoma, because osteosarcomas in certain areas are very uncommon, and they are, to a certain extent, diagnoses of exclusion. So why is it important to know the varied morphological appearances in certain entities? It is very important because when you get a biopsy, you should be able to think of certain entities, particularly entities that require preoperative treatment in a certain manner, whether be it preoperative radiotherapy, or some cases where if it's inoperable, they can be given adjuvant chemotherapy. So gastrointestinal stromal tumor is a good example of such tumors. We often get very small biopsies in tumors that are inoperable, and we should be able to make a diagnosis of a gastrointestinal stromal tumor, even though, the morphological appearances may be quite varied in those particular entities. So using a range of immunohistochemistry is what's helpful, and not to rely on a single immunostain. Here I've put 4 immunostains that are usually positive in gastrointestinal stromal tumors, but these immunostains are not specific for gastrointestinal stromal tumor. That's the the important thing to remember, that if one were to rely on a single immunostain, you can make mistakes. CD34 is typically a marker of endothelial cells. So if you do it in isolation, you can make a diagnosis of an angiosarcoma when in fact it's a gastrointestinal stromal tumor. If you do CD117, it also stains mast cells, it also stains other tumors. In isolation, again, you can make mistakes. H-Desmond is typically a smooth muscle tumor, and smooth muscle tumors morphologically often mimic leiomyosarcomas. So context and doing a range of immuno does help us to avoid mistakes. And in some cases, we get biopsies where a tumor looks like a sarcoma. And if you were to stain it, you would believe that it's a sarcoma, when in fact it's not a sarcoma. So we ought to think of other tumors that have the same morphological appearances. And if you think of those entities, you then apply the necessary investigations to try to differentiate them from sarcomas, because you can only diagnose what you know or what you have thought of. If you haven't thought of it, you can easily make an erroneous diagnosis. So things like carcinomas, they can have a spindle cell morphology and look very much like a sarcoma. And also carcinomas can have mesenchymal sort of differentiation or heterologous differentiation. You can have a carcinoma with osteosarcomatous differentiation. You can have a carcinoma with chondrosarcomatous differentiation. Those are the things that we look out for in the biopsies. Here is an example of a case we had years ago. It was a 72-year-old who had a chest lesion and at the same time was diagnosed with lung metastasis. And there was a biopsy which was done. And the biopsy looked like this. These are large cells with abundant cytoplasm, more like the smooth muscle, rather the skeletal muscle cells that I showed you earlier on. And the peripheral hospital where the biopsy was done, they saw that and they did the markers for skeletal muscle differentiation, and lo and behold, they were positive. So it was positive for desmin, myogenin, MyoD1, which are the typical markers we use to confirm skeletal muscle differentiation. So a diagnosis that was proposed then was that of a pleomorphic rhabdomyosarcoma. When we had the patient reviewed, the patient had a relatively small lesion in the chest wall, and the lesion was very superficial, mainly based within the skin, which seemed odd for a sarcoma. And that was then resected, and on resection, in addition to the appearances that were seen in the biopsies initially, we could also see that away from the center of the lesion, there was what looked like a junctional component. By junctional component, we mean where we have cells that are interacting with the epidermis, which is something we typically see in melanomas. And we did melanoma markers. So at the periphery, the tumor showed melanocytic differentiation. And at the center, it confirmed what was seen in the biopsy, that it showed rhabdomyoblastic differentiation. So this was a malignant melanoma with divergent rhabdomyoblastic differentiation. So it's, again, just to illustrate that sometimes things are not what they seem, on first look. We have to apply, our clinical knowledge and try to correlate whatever clinical information we have, and then do the necessary investigations and come up with the right diagnosis. These days, this particular patient would have benefited from, more targeted treatment for melanoma patients. The other thing is with more and more molecular studies being done, we are getting some entities that can only be diagnosed by doing molecular studies. And this is, again, a source of diagnostic difficulties that we get. And if you are working in a peripheral hospital where maybe you don't have the access to some of the molecular studies, it can be difficult to diagnose. A good example of how things have changed over the years is the so-called small round blue cell tumors. We used to have just Ewing sarcoma and then other undifferentiated sarcomas, but over the years, the group of undifferentiated sarcomas, NOS, has shrunk to a very small subset of these tumors. Now we have in many of these entities which are defined by the underlying molecular abnormality. Yeah. So pathology really is necessary. It underpins, the practice of particular sarcoma treatment, because not only does it provide the diagnosis, it directs treatment in some cases. And we've moved on from traditional pathology where we just used to make the diagnosis and stop there. These days, we also look for biomarkers. We also direct treatment, and by providing staging of tumors, we give information that underpins prognosis. I will leave you with this slide here.